Are you a medical student building a foundation, a doctor or a healthcare professional seeking to refresh your knowledge, or just someone who is passionate about understanding diabetes and its impact? Then worry not, you are at the right place. In this session, we'll cover the latest evidence-based updates on diabetes management, complications, and some of the prevention strategies with practical insights that can help you in clinical practice and in daily life. Diabetes continues to wreak havoc in many healthcare systems globally, and understanding the latest updates is critical in improving our patient outcomes. If you're new in this channel, don't forget to like, share, and subscribe to help us create more CME-focused content on medicine and clinical practice. Welcome to today's continuous medical education on diabetes mellitus. My name is Ruben Omondi. Let's get into it after the short introduction. So first things first, let's get into the introduction. What is diabetes mellitus? In this session, we'll be calling it DM. DM means diabetes mellitus. So forget about all the other DMs that you know. Here it implies diabetes mellitus. So it is a chronic metabolic disorder that is characterized by sustained elevated blood glucose levels, which results from three things. First, impaired insulin secretion. The second is impaired insulin action, or both. Or both means both. There is both impaired insulin secretion and impaired insulin action. So there are three parts of that definition that I want us to capture. The first is that it is a chronic metabolic disorder. This means that it comes chronically in our systems and it affects the metabolic systems in our body. And then second thing is that it is characterized by sustained elevated blood glucose levels. What does this mean? You can have an elevated blood glucose levels, but they are not sustained. It comes once in a while or because of other factors. That situation is not called diabetes. But if they are sustained elevated blood glucose levels, then this we could be having a situation like DM. And the last part is that these sustained elevated blood glucose levels are as a result of three things. One, impaired insulin secretion, or it could be as a result of impaired insulin action, or the last part, it could be as a result of both of these two, which is both impaired insulin secretion and impaired insulin action. I hope you understood. So we go to the second part of this.
On to the second part, let's talk about the epidemiology. So the prevalence globally as of the moment is at around 10.5%, and type 2 diabetes accounts for 90% of diabetes cases globally. This tells you how much people have changed in terms of lifestyle and the way of living, nutritional aspects of our lives. And this, as this continues to change, as people continue to embrace sedentary lifestyle, then type 2 diabetes will continue to rise. Again, Africa just has around 24 million cases, which is below 50% of the global prevalence. The reason why Africa still records low cases is because of diagnostic approaches. I think in Africa we have not embraced regular screening of diabetes, and this makes diagnosis of diabetes really at a slow pace as compared to the Western countries, where this screening is more regular, and this makes many people be diagnosed with this disease. So the prevalence in Africa is low compared to the Western regions, but the fastest growth is expected, and it's projected to increase by 134% at least by 2045. Why? Because we expect that as we continue with urbanization, and as people embrace more of this education like the ones we're having today, then we will have an increased rate of screening, and this will increase the diagnostic approaches. And this can become clear if we look at the picture from a regional and local perspective. Let's just look at the data in Kenya. In Kenya, the prevalence is at 3.1%. That is according to 2019 International Diabetic Federation data. And this data projected that by 2035, we will have around a rise from 3.1 to 4.5%, 4.4% prevalence. And then, of course, you see that most 60% of Kenyans have not been diagnosed with this disease. They have it, but they have not been diagnosed. Why? Because screening is not being done regularly. We have to embrace screening of these diseases as part of management, because prevention is better than what? Than cure. So, of course, late diagnosis contributes to high morbidity and mortality. It also states that most Kenyans, over 88%, are dying of diabetes without knowing. So you see, again, screening is very important. So as far as epidemiology is concerned, Kenya's prevalence is at around 3.1%, and we expect this number to rise as we continue to live, because people continue to embrace more modernized way of living. People continue to embrace sedentary living. People continue to indulge in poor nutritional habits, and this contributes to the higher risk factors for having diabetes, especially type 2 DN. But of course, type 1, we expect that it will always come earlier in age, at around 30, 31. Before 35 years, if you have type 1 DN, then most likely you will have it diagnosed earlier. You shall have presented with symptoms like that, like those of type 1 DN, and that diagnosis will be easier at that particular point. So let's go to the second part of this. I want to talk about the types of diabetes, and of course, I'll just major on the main ones. There are many other types. There are many other subtypes. IDF in this course will be International Diabetic Federation, considered subclasses of diabetes in the recent presentation, and I think there are many others more than the ones we know. So before we get to those others, let us just have these ones understood. So I'll start with type 1 DM. And from our definition, type 1 DM is the one that occurs as a result of impaired insulin secretion. Just like that. Type 1 DM is a chronic autoimmune disease associated with selective destruction of the insulin producing pancreatic beta cells, and this leads to deficiency in insulin secretion. So there are those cells that usually stimulate insulin production, and they're the pancreatic beta cells. So these pancreatic beta cells are the ones that are involved in the production of insulin. So if they are regularly destroyed by processes we do not know, research has not verified how these pancreatic beta cells are destroyed. So it is an autoimmune disorder, because these pancreatic beta cells are destroyed as a result of autoimmune processes that we do not know what causes. But of course, there are risk factors that have been linked to this destruction, but these link factors cannot work solely as the causative agents for diabetes. Why? Because there is no research that has verified at 100% that this risk factor is the one that has caused this. Why? Because we have others who are having those risk factors but do not have these pancreatic beta cells being destroyed. For that reason, they're just classified as risk factors, because you having them predisposes you to higher chances of having your pancreatic beta cells being destroyed, and this will lead to insufficient insulin secretion. So when we have insufficient insulin secretion as a result of those autoimmune processes that destroy the pancreatic beta cells, then you will end up with type 1 diabetes. No, let me repeat type 1 DM. Type 1 DM is as a result of chronic autoimmune processes that lead to the destruction of the pancreatic beta cells, leading to the deficiency in insulin secretion. So insulin is not being produced. In simple terms, insulin is not being produced, type 1. So this means that the management of this patient is going to focus primarily on insulin. You may have other methods you want to include in this, but the management primarily is going to focus on insulin, because one, insulin is not being produced. Now we'll talk about that more as we continue. The second type is type 2 DM. This one is the most common one. We have read, or we have established from our epidemiology, that it accounts for 90% of diabetic cases globally. Again, it is the most underdiagnosed. Why? Because it comes late in age, and most people probably even die with this type of diabetes without knowing, because it is not properly diagnosed. And many people who do not do regular screening end up not screening for this, and this is really dangerous. So type 2 DM is characterized by two things. There could be impaired insulin secretion, again, This one is not at 100% impaired insulin secretion. Insulin is being produced, but not enough. So it still has an issue with impaired insulin secretion. And of course, the second part is because of peripheral insulin resistance. So type 2 is majorly because of insulin resistance, and it could also be coupled up with impaired secretion. Impaired secretion means the secretion is still taking place, but at a very small amount, at a very low rate as compared to that of a normal person. So this one manifests late in age, and as we have said, the diagnostic approaches are still not up to date. Another type of diabetes that is of interest to our population is gestational diabetes. It is usually diagnosed mostly in the second or third trimester, and this occurs mostly in a woman who was not previously known to have diabetes. But it could also occur in a woman who was known to have diabetes, but the sugars were properly controlled, and then in the second or third trimester, then there is high blood sugar levels that are suddenly not being controlled by her usual dosages of medications. So if we have this in that woman, then it will be called GDM superimposed on chronic diabetes. And then for that new woman who has not been previously diagnosed with DM, then this one would be what we call GDM. It usually occurs as a result of these pregnancy hormones that are elevated in pregnancy. The first one is the human placental lactogen. Human placental lactogen is an hormone that is produced by the syncytial trophoblast. For those who do not know, this production is meant to help in reserving sugars for the fetus, reserving enough energy for the fetus so that it aids in development of the growing fetus. So the human placental lactogen may result in impaired insulin activity, and this could lead to peripheral insulin resistance as a result of trying to reserve energy or sugars for this child. The child gets sugars through what we call the placenta, and the placenta has to help in maternal and fetal blood circulation. So these sugars in the mother are the same that have to go to the child, and this child uses them for growth. So human placental lactogen, in the process of preserving these sugars to the baby, may lead to the woman developing what we call GDM. Again, another hormone, of course, is progesterone. You know what progesterone does in pregnancy. If you are a medic, progesterone is used to maintain pregnancy. It helps in relaxation of the smooth muscles, and this helps to prevent preterm labor. It helps to prevent premature dilatation of the cervix. These women coming with cervical insufficiency issues, then we give them progesterone to try and maintain the integrity of those muscles so that the pregnancy can be contained to term. So in the process of doing that, it relaxes these muscles. When the muscles relax, as we shall see in the pathophysiology, then it means that they are not using sugars. So the muscles have to be in activity or in contraction, or they have to be stimulated frequently for them to help in the utilization of sugars. So an abundance of progesterone, which results into the relaxation of these muscles, leads to impaired insulin activity again, and this could again cause peripheral insulin resistance during pregnancy, and that causes GDM. Other hormones, of course, that cause this are the prolactin. Prolactin initially increases the mass of pancreatic beta cells. Like we saw, the pancreatic beta cells are involved in insulin secretion. So if their mass is increased, it means it's going to produce a lot of insulin. Again, as we shall see in the pathophysiology, with increased insulin production, then we could easily have peripheral resistance. So that again may lead to GDM. One thing I want us to know about GDM is that it is often asymptomatic most of the time and needs to be screened for. Again, it is associated with poor pregnancy outcomes. You could easily lose both the mother and the child when they have GDM. So we need to screen for it regularly. When you go to the hospital and you're pregnant, just try and screen for all these things to help alleviate the risk of bad outcomes. So it usually resolves after delivery. If it is GDM, then after delivery, at most 6 weeks postpartum, then you're supposed to be free from GDM. And then, of course, it is aggravated by risk factors. Some of the risk factors are overweight, of course, genetic susceptibility, and then age. Some of you want to give birth at old age. With old age, all these cells have been frequently used, and insulin is not at its topmost functional level. Of course, if you are diabetic, you also have risk of GDM. Of course, there are those ethnic or racial factors, and there are other factors such as the PCOS. We'll talk about PCOS some other time. But if you have polycystic ovarian syndrome previously before pregnancy, then you could have beta cell dysfunction. You could have hyperandrogenism, and all these lead predisposes to GDM. I hope that is understood. So, what are some of the differences between type 1 and type 2 DM? From the definition again, 1 is as a result of insulin secretion impairment, that is type 1. So, type 1 is as a result of impaired insulin secretion. Type 2 is as a result of peripheral insulin resistance. So that is impaired insulin action. Again, type 2 could also be because of partial impairment of insulin secretion. That means insulin is being produced but not in sufficient amount. Again, with that age comes the factor of age. So type 1 comes early in age, usually diagnosed early in age, mostly below 35 years. This doesn't mean that we cannot have type 2 early in age. Some of us have lived poorly and have really bad lifestyle. And this could predispose us to having type 2 early in age. Even at 20 years, we could have type 2 DM because of how we have lived, as we shall see in the risk factors. So, but of course, type 1 mostly occurs below 35 years of age, and this means that the insulin production or secretory impairment takes place, and then type 2 occurs later in age, that is above 35 years of age. And this tells us how type 2 occurs. Type 2 occurs as a result of there is impairment of insulin action. This occurs with time. The insulin cells, and because we are continuing to live a sedentary life as we grow with age, then it predisposes us to type 2 DM late in age. About weight, type 1 always leads to rapid weight loss, and that occurs before the diagnosis. But of course, type 2 is mostly from normal to overweight at diagnosis. You diagnose it when people are having that risk factor really evident in themselves. There is no insulin resistance in type 1, but of course in type 2 we have insulin resistance. There is usually high levels of ketosis, that is ketoacidosis, and this we shall see why DKA mostly occurs in type 1 and not in type 2. But of course in type 2 we could have ketogenesis or ketosis, but not as much as in type 1 DM. And then of course hereditary factors, those genetic susceptibility factors are more common in type 2 DM than in type 1 DM. So, of course, metabolic syndromes are usually absent in type 1. We do not have the metabolic syndrome, but of course, in type 2, they are present. We could have a cluster of cardiovascular disease and those risk factors that are present with type 2 DM. We have hyperlipidemia. All these predisposing factors of life are more abundant in type 2 DM as compared to type 1 DM. And then of course type 1 treatment is majorly insulin therapy. There is a very limited role of other drugs in type 1, but of course in type 2 we could do the lifestyle changes, we could do dietary modification plans, we could do everything from nutritional rehabilitation, we could do oral glucose lowering agents. All these could happen in type 2 but cannot happen in type 1. And then of course acute complications. In type 1 we have DKA. In type 2 we could have DKA, but mostly what usually comes in type 2 is what we call hyperosmolar hyperglycemic syndrome, HHS, hyperosmolar hyperglycemic syndrome. And then type 2 hyperglycemia is associated, hypoglycemia may be associated with the treatment. That means because we're using insulin, we could have much hypoglycemia. But of course, hypoglycemia could also occur in type 2 if we're using insulin alongside other drugs. But of course, it is not as common in type 2 as it is in type 1. I think that is a summary of the differences between type 1 and type 2 DM. So let's get into one of the most important segments of this discussion. If you are not listening, start listening, because if you miss this, you will miss a lot of things in diabetes. So I want to talk about the metabolic homeostasis, and this forms the pathophysiology of diabetes. Okay, so let me just start from a layman's perspective. I want these people who did not study medicine, these people who did not go to a medical school, to try and understand it from this point. No, what happens? I take food and then I take it orally. It is broken down from the mouth, and then digestion of carbohydrates begin in the mouth. There is starch, and then we go down. Peristalsis occur in the esophagus, pushes it down the stomach, and then it gets into the stomach. There we have a lot of things being produced. We have the peptides, peptic acid, hydrochloric acid, and gastric juice. They help in the digestion of what? Proteins. And then they go down further into the intestines. The intestines are divided into two parts, the small and the large intestines. So in the small intestines, what happens is that the food is absorbed into the bloodstream. You get me? Now start getting it from that point. It is absorbed into the bloodstream, the food that you have eaten. So what usually happens? The food that you eat is broken down into the smallest possible units, which are the monosaccharides. Now these monosaccharides are the ones that are absorbed in the bloodstream. Now there is where the problem begins. They are absorbed in different ways. We have fats that go through the lymphatic system. We have proteins that are absorbed in form of the amino acids, and then of course all these are there in blood in form of the smallest possible units that we could have. So in blood there has to be what we call homeostasis, and this is where this metabolic balance occurs. The work of insulin is to help in absorption of this sugar that is now in blood. It has been absorbed by the villi. You remember the villi, the finger-like projections in the small intestines that help in the absorption of food. Now the villi absorbs this food that we have taken, and now there are sugars in blood. The reason it has been absorbed is to transport it to various parts of the body for need, for action. For example, the brain needs a lot of sugars for it to be able to function. The brain needs a lot of sugars for it to be able to think and to aid in your day-to-day activities. The heart muscles needs a lot of sugar for them to be able to pump blood efficiently to all parts of the body. Your skeletal muscle cells, when you move, when you work, when you do everything that you do, they need these sugars for them to be able to perform those activities. So insulin transports them to the needy cells. Now, if you are frequently using your skeletal muscle cells, it means that insulin will reserve a lot of these sugars that are now in blood to those muscles for those use. If you are you're doing a lot of thinking, a lot of what, then a lot of sugars, your brain will need a lot of energy for them to be able to do what? For it to be able to process everything that you do. So the transport of these sugars from blood is dependent on need. And this takes us to some of the risk factors that we have as far as diabetes is concerned. If we live a sedentary life, we don't stimulate our activity as frequent as possible, then it means that the demand is going to be low and they're going to accumulate in blood, and this is one of the risk factors that predisposes us to peripheral insulin resistance. So the metabolic homeostasis is initiated by the hormone we call insulin. So there are two things. There are those processes that insulin inhibits, and then there are those processes that insulin stimulates. By doing this, insulin is able to control blood sugar level. So what does insulin inhibit? Number one, insulin inhibits four major processes that I want to take you through. The first one is what we call glycogenolysis. Okay, so the second one is called lipolysis. The third one is gluconeogenesis. And the last one is proteolysis. That is the process by which proteins are broken down. So let's start with the first one. The first one I want to talk about is gluconeogenesis. Insulin inhibits gluconeogenesis. What is gluconeogenesis? Gluconeogenesis is the process by which sugars are formed from non-glucose compounds in the body. So we have already learned that glucose is that sugars are there in blood. So there are points in our normal life where there is no sugar in blood, or these blood sugars are so low and we need them. So what will happen is that glucose will be formed from non-glucose compounds in the body. What are the non-glucose compounds in the body? They are the fatty tissues. They are the sugars that are there in the adipose tissues and in the proteins. All these are non-glucose compounds in the body. So if sugar is formed from proteins in the body, it is called gluconeogenesis. If sugars are formed from lipids, then it is called gluconeogenesis. So formation of glucose from non-glucose compounds is what we call gluconeogenesis. Now, insulin inhibits means it prevents this. So if you have insulin, usually that is how it controls sugar levels. It will prevent gluconeogenesis. Understood? It will prevent additional sugars from those non-glucose compounds because we already have our glucose compounds. Insulin does not want too much sugars in our system, so it prevents gluconeogenesis. So the other thing that insulin inhibits is glycogenolysis. So glycogenolysis is the process by which glycogen is broken down into glucose. Now, if it is broken down into glucose, it will of course increase the abundance of glucose in blood, and that is why insulin inhibits glycogenolysis. What do I mean? When we have a low supply of insulin or no insulin, it means that glycogenolysis will increase. If it increases, it will contribute to the abundance of blood sugar levels. So the work of insulin is to inhibit or to prevent glycogenolysis, and in this way, it controls blood sugar levels. Another thing that insulin prevents is what we call lipolysis. What is lipolysis? Lipolysis is the breakdown of lipids. Lipids are usually formed by fatty acids and glycerol. Those are the simplest forms of lipids. Now, if we have fatty acids and glycerol in blood, it means that lipids are not being formed. So if they are broken down, then we have an abundance of fatty acids and glycerol in blood. If they are not broken down, then these fatty acids and glycerol contribute to the formation of triglycerides that are now deposited in where? In the adipose tissues of humans. So insulin prevents the breakdown of these lipids into fatty acids and triglycerol. So if we do not have lipids, if you do not have insulin, then it means this breakdown will increase, and this may result into the formation of extra sugars in form of in form of fatty acids and glycerol. Again, if we have many free fatty acids in the blood, then this could contribute to what we call ketosis, because these free fatty acids are the ones that end up forming what we call ketone bodies, as we shall see ahead. Again, insulin prevents proteolysis is the breakdown of proteins into amino acids. Of course, proteins are formed from amino acids. Now, once they're absorbed into the bloodstreams, they're absorbed in form of amino acids, and then these amino acids are the ones that are used for various factors in the body. So these amino acids contribute to high blood sugar levels. So insulin does not want them in blood. So insulin will stimulate the formation of proteins from them, and these proteins are used in the building of muscles and other factors in the body. So and repair of worn out tissue. These amino acids are used to form proteins that are essential in the in the repair of worn out tissues and building of our muscles and our body's growth. So if we do not have insulin, it means that proteolysis will increase. The proteins that are available will be broken down even further, and this again will contribute to what? An increase in blood sugar levels, or rather they will not be formed. And if they're not formed, then it means they will be abundant in blood in form of sugars, and this contributes to high sugar levels. So I've talked about four things: what insulin inhibits, and whatever insulin inhibits is what contributes to high blood sugar levels. The first one is gluconeogenesis. If insulin is not there, gluconeogenesis increased, and that means that there is a lot of sugars being formed from non-glucose compounds that are now abundant in blood. The other thing that insulin inhibits is glycogenolysis. Glycogenolysis is the breakdown of glycogen that is stored in the liver and the skeletal muscle cells. If they are broken down, it means they contribute to an abundance of blood sugar levels, and this contributes to sustained elevated blood sugar levels, what we call hyperglycemia. So again, insulin inhibits glycogenolysis. Another thing that insulin inhibits is lipolysis. Lipolysis is the breakdown of triglycerides into their constituent compounds, which are the fatty acids and glycerol. The fatty acids are not supposed to be abundant in blood. If they're abundant in blood, they contribute to what we call ketosis, because they are the ones that end up forming the ketone bodies. So if we have a lot of ketone bodies and glycerol also too much abundant in blood, then we could end up with that situation, which results into too much ketone body synthesis, and that leads to DKA. So insulin prevents lipolysis, and this, by preventing lipolysis, it is able to control blood sugar levels. Again, insulin prevents proteolysis. This is the breakdown of proteins into the constituents amino acid compounds. Proteins are used in repair of worn out tissues and building of our muscles. In every other part of the body that needs development, protein helps in this. So if they're broken down into the constituents compounds, it means that they're not being utilized for these other functions, and this will let them be abundant in blood. So insulin serves to prevent that breakdown. Now, what does insulin stimulate? Takes us to the second part of this metabolic homeostasis. What does insulin stimulate? So insulin stimulates what we call glycogenesis. Glycogenesis is the opposite of glycogenolysis. Glycogenolysis breakdown, glycogenesis formation. Now, insulin helps in glycogenesis. How does it help in glycogenesis? Glycogenesis is the formation of glycogen from glucose. Now, this glucose that is abundant in blood, insulin converts it into glycogen, stores it in the liver and the skeletal muscle cells. The reason it takes it to the skeletal muscle cells is for activity. I told you you have to be active, and also to reserve some of them in form of glycogen for use in crisis. Okay, so insulin stimulates glycogenesis. Again, insulin stimulates lipogenesis. Once you take food in form of lipids, they are broken down into the smallest units, which are the fatty acids and glycerol. For them to be formed, for triglycerides to be formed from fatty acids and glycerol, you need insulin. Which means if you don't have insulin, they will be abundant in blood, and that contributes to the high blood sugar levels. Again, insulin stimulates glycolysis. Glycolysis now is the uptake of glucose that is in blood by the skeletal muscle cells, and this usually happens by the GLUT4. We shall talk about that next. Again, insulin stimulates protein synthesis. Protein synthesis is the stimulation or the uptake or the formation of proteins from the amino acids, which are the smallest compounds. So once they get into blood, it has to be stimulated for them to form proteins that are now used in what? In the development of the repair of our worn out tissues and the development of our musculature and other parts of the body. So let me just repeat again. Insulin stimulates glycogenesis, which is the formation of glycogen from glucose. Of course, that will help to reduce the sugars that are abundant in blood. It stimulates lipogenesis, which is again helpful in reduction of blood sugar levels. It stimulates glycolysis, which helps in the uptake of the glucose that is now abundant in blood. And lastly, it promotes protein synthesis, which again helps in the utilization of sugars that are abundant in blood. Now, once you understand that, any impairment in that metabolic activity, which in diabetes results from either insulin actions impairment or insulin secretion impairment, or both, then you know it will affect this metabolic activity, and then the resultant effect is sustained elevated blood sugar levels. I hope you understood. So let's even understand this pathophysiology better. So where insulin, this is a situation where insulin is not functional. I've told you what insulin does. So what happens when we have an impairment in insulin secretion That means type 1 DM. Insulin is not there. So let's go. We have the liver here, and you see what happens in the liver. There will be reduced glucose uptake. Means that this liver needs glucose for its function as well. So it will not take it up in appropriate amount, and it is going to increase in blood. Again, in the liver, we said we have glycogenolysis or glycogen. So that glycogen that stores sugar in form of reserve is going to be broken down. It's broken down, it's called glycogenolysis, and that breakdown increases the blood sugar levels. So they're going to be abundant in blood again because insulin is not there. Again, there is a process we call gluconeogenesis, which is the formation of sugars from non-glucose from non-glucose compounds. Once it is formed from non-glucose compounds, it means there is so much again that is going to be dumped in blood. So if it is formed from gluconeogenesis, this happens because insulin is not there or is not active. Then it's going to increase again in blood. The resultant effect is that there is sustained elevated blood glucose levels. And then ketone production, of course, is also going to be initiated. If we do not have insulin, then it means that lipolysis is going to take place. And when lipolysis takes place, it forms free fatty acids and glycerol that increases again blood glucose levels and increases the free fatty acid that lead to formation of the ketone bodies. Ketone bodies are the ones that lead to acidosis. We shall see that when we talk about the complications of DM. Again, blood glucose level control. This is just a summary of it all, with or without insulin. So let's just summarize again from this chart. What is the function of insulin? What does insulin stimulate? Insulin would stimulate glycogenesis. Glycogenesis is not going to be possible here. So what we have is the opposite of it, which is glycogenolysis. Insulin is supposed to stimulate glycolysis. Glycolysis is the uptake of glucose by the skeletal muscle cells. Again, you see here glucose uptake is down, so that means it's not going to happen. That glucose is going to remain in blood and it's going to be abundant. That leads to diabetes. Again, insulin is supposed to help in protein synthesis. Now, if insulin is not there, again, it means that protein synthesis is not going to take place. Instead, the breakdown is going to occur, and we're going to have so many other proteins in blood, and that is what happens. Protein breakdown to amino acids is going to increase, and that synthesis from amino acids is not going to take place, and the resultant effect is that there's going to be increased blood sugar levels. Again, insulin not there. Triglycerides, are they already formed fats? They are not going to be broken down. They're going to be broken down more into fatty acids. And if we have too many fatty acids, just like here, we're going to have many ketone bodies. And as a result, again, with ketone bodies and a lot of free fatty acids and glycerol, the resultant effect increased blood sugar levels. So this is how without insulin you can have diabetes.
Well, let's get to the other part of this. Let's talk about the clinical manifestations, and we're going to pick it up from pathophysiology to help us understand it even more. So, just a quick recap: we said that DM is caused fundamentally by either a problem in insulin secretion or insulin action, or both insulin secretion and insulin action. So the beta cells of the pancreas are impaired, and this affects their activity in terms of insulin secretion. Once this activity is impaired, whether insulin secretion, whether insulin action, or whether both, they are going to lead to what we call sustained elevated blood sugar levels. And the resultant effect of sustained elevated blood sugar levels is that there's going to be hyperglycemia. And when we have hyperglycemia, then these sugars are transported all over in blood. So the first effect is in the kidneys, and part of the ultrafiltration there, we're going to have too much glucose going out in urine, and this is the first sign, glucosuria, glucose in urine, that can be detected in urinalysis. When you do a urine analysis test, we will be able to see glucose in urine, and that is glucosuria. Now, once we have glucose in urine, start to understand from here. There is something we learned in class 7, class 5, and form 1, form 2, something we call osmotic pressure. Now, osmotic pressure will come about because there is too much glucose in urine, and that makes that solution, that ultrafiltrated solution, to be too much concentrated. And because it is too much concentrated, it is going to attract water from every other part, from the renal tubules, from every other source. and this is what we call osmotic diuresis. Now, once we have osmotic diuresis, you're going to pass out too much urine, and this too much urine and frequent urination is the second sign. So we have already glucose in urine, first sign, and then what else? Too much urination. And then once you're urinating too much, you're going to lose water, and what happens is that your brain is going to be stimulated through the hypothalamus. It's going to sense that you are losing water, so you're going to feel thirsty to try and rehydrate yourself to add onto that volume that is being lost, and this leads to you being thirsty. Now that's the third sign. It's called polydipsia, the feeling of being thirsty. And then once you feel thirsty, there is the third sign we call polyphagia. How does polyphagia come about? It's because there is too much sugar in blood that is not going to your metabolic cells. The cells need them. The metabolic activities need energy. The brain needs energy. And every other part of your body that functions needs energy, but it is not having it. Why? Because it is abundant in blood. It is not being able to be absorbed into all those other bodies, as we saw in the pathophysiology, because insulin is either not being secreted at all or being secreted in very limited amounts, or both of the two. So what's going to happen is that there is that block. These sugars not going into the cells. Now, those who are arguing and saying that there is usually too much sugar in the cells, this is your area of enlightenment. There is limited sugar in the cells, and that is why there is polyphagia. The second thing, we are also going to have fatigue and tiredness, another clinical sign, because of the same reason. Because these sugars are not going into these cells, not skeletal muscle cells, not even in the brain. We are not having them enough, and so we have to feel fatigued and we have to feel tired. Now, there is also an intentional weight loss. How does this come about? Because there is not too much sugars that are being taken in for energy, you're going to have weight loss. Why? Because the fats are going to be burned. The adipose tissues are going to undergo too much lipolysis to try and sustain these body metabolic activities and other activities of the body. In the process, once the adipose tissues are being depleted, then you're going to lose weight. But of course, if you do not check on yourself very well, you may end up regaining weight once you start taking diabetic medications, because insulin will reactivate the pump, and then these excess sugars will stop being broken down, as you have seen that it happens here. So in diabetes, there is going to be that unintentional weight loss. We have other signs such as loss of consciousness. They come in DKA. We have cool small breathing. They come with complications. Diabetic foot, will cover those when we address the complications. But for now, I just want us to have that summary of the triad of clinical signs that come with the pathophysiology, and that is the glucosuria. Glucose in urine leads to osmotic diuresis. Then you have too much urination, that is polyuria. Once you urinate too much, the hypothalamus is stimulated, we feel thirsty, and once we feel thirsty, that is what we call polydipsia. Polydipsia, we also have then polyphagia, because the cells are not getting enough sugar, so they stimulate you to feel the urge of eating too much, and then we're going to feel tired and fatigued because of the same reason. And then there's this other sign called, this other sign we call blood vision. How does blood vision occur? Blood vision occurs because there is going to be too much sugars, and part of the circulation in the eyes are going to have a lot of sugars, and this affects the osmotic balance of the eye lens as well. And when the osmotic balance of the eye lens is affected, then the refractory activity is going to be altered. Once the refractory activity is altered in the eye, you're going to have blood vision, and then unintentional weight loss. Let's get to the next part, which is how to diagnose diabetes. So, getting into the diagnosis of diabetes, how do we diagnose this disease? What are some of the tests that will help us to diagnose this disease? Of course, the first and the fundamental way of diagnosing this disease is by identifying the clinical signs and symptoms that we have just addressed. So there are four tests that I'm going to give you that can help you to diagnose this disease. The best, I know the most common one is usually the random blood sugar. And the random blood sugar is not a reliable test. Why? Because you can just take this test once a person has taken too much sugars. Those meals that have a lot of sugars, and they are usually absorbed very fast in the bloodstream, like energy drinks, and these ones can spike your blood sugars temporarily. So if you take a test, a random blood sugar at that moment, you may end up having probably high or a pre-diabetic blood sugar level that is not realistic. So however, it is an index, a suspicious, and it's like a clinical symptom. If we see an RBS that is high, then it could be an indication that you have diabetes. And then an RBS for a diabetic patient is not as similar to an RBS of a non-diabetic patient. Why am I saying this? For a diabetic patient, we already know they are diabetic, so the sugar ranges we know are supposed to be at a certain level, and because we're using an RBS for them, we can use it to assess the usual blood sugar levels. We can try to know whether they have eaten or not, and then range these RBS to the usual blood sugar levels. So for a diabetic patient, RBS is very important. For a non-diabetic patient, RBS is just like a clinical sign that we can use to have suspicions on whether you are diabetic or not. Now, once we have done an RBS, as we talk about RBS, we can also talk about the second one. This is the FBS. FBS is the fasting blood sugars, and these ones is just an RBS that is taken before you take your meal. So the fasting blood sugar is not like the random blood sugar. It is usually taken after you have fasted and then you have stayed without food for at least 8 hours. Once we take it, we expect that it should come below 5.6. If it comes to 5.66 and above, then that is a pre-diabetic situation. If it is beyond 6, at 7 and above, and it's a fasting blood sugar levels, then you are diabetic and you need to be assessed properly. Now, it cannot be used as the ultimate diagnosis of diabetes. Why? Because it is just taking the blood sugars of that moment. Now, the one that is now used to determine whether you're diabetic or not is the HbA1c. It is the glycated hemoglobin test. Now, this one, it gives us the test, the range that is between 2 to 3 months. So it gives us the sugar ranges that have been there in your system for the last 2 to 3 months. Now, anything that is above 6.5 in HbA1c is diabetic. Anything that is just between above 5.7 is pre-diabetic. Anything 6.5 and above, diabetic. Anything 5.7 but below 6.5, pre-diabetic. And then anything below 5.7, as we can see, is normal. So HbA1c is the ultimate marker for understanding whether you're diabetic or not. And then we also have this one, we call it OGTT. So mostly we use it for gestational diabetes. I'll tell you how it is useful there. But in this test, the patient fasts overnight, and then the baseline FBS is usually taken, and then given around 75 grams of glucose to drink, and then we repeat that the glucose at 2 hours. Then that diagnosis is given after taking that 75 g of glucose, and then we are supposed to assess whether you are orally tolerant to glucose. Now, if these blood sugars go beyond 200, that is 20, beyond 11, then this one we call you are in a diabetic situation. If they are between 7.8 and 11, then you could be having a pre-diabetic situation. If they are beyond 11, then you are diabetic. But if they're below 7, then that OGTT is normal. We'll talk more about this when we talk about gestational diabetes someday on itself as a unit. And then I think those are the most common tests that we can use to diagnose diabetes. If you have any other, you can tell us. Let's just do a summary of these tests that we can use to diagnose diabetes. We have said RBS, which is the random blood sugars. We have said RBS, which is the random blood sugar taken at any time of the day. And then this one is not a single indicator because it may be at a point when you have eaten. So it may not be give us the correct picture, but it is treated as a clinical sign. Once we see this one is high, it gives us a high index suspicion and makes us do other tests that will help us to confirm whether it was diabetes or not. Now, RBS done after you have fasted more than 8 hours is what we call FBS. Now, usual FBS is not supposed to go beyond 7. Now, if it crosses 6.9 and goes to 7 and above, yet you have fasted for 8 hours, that is diabetes. But if it is slightly above 5.6, that is a pre-diabetic situation. Below 5.6 FBS is a normal test. And then we have, of course, the HbA1c, which I have told you it is the one that is useful in diagnosing diabetes. It is the one that is useful in diagnosing diabetes. It is the glycated hemoglobin test, and a test above 6.5 is diabetic. A test that is below 5.7 is normal. A test that is just between 5.7 and 6.4, or that is called a pre-diabetic situation. So an HbA1c can help us to diagnose diabetes. It is the one that gives us the accurate value because it shows how blood sugars have been controlled over a long period of time.